All right, good morning. Thank you so much for the opportunity to present today. We have no disclosures. A laparoscopic approach to surgery for diverticulitis has been favored in the elective setting, with evidence that outcomes and costs are superior to the open approach. Laparoscopy has also been increasingly used in the urgent and emergent setting as well. And diverticulitis poses a significant burden specifically to the older population. Elderly patients are at a particular risk when undergoing surgical interventions, especially with higher rates of comorbidities. Nevertheless, laparoscopy has been shown to be a potentially safe approach for elective colorectal surgery in prior studies. However, there's limited research focusing specifically on the outcomes of laparoscopy for acute diverticulitis in the elderly population. So, therefore, the aim of this study is to compare the short-term outcomes of laparoscopic versus open surgery for acute diverticulitis among elderly populations in both the elective and non-elective settings. So we conducted a retrospective database study using the ACS NSQIP database from years 2015 through 2019. We included adults aged 65 and older with ICD-10 diagnoses of acute diverticulitis and who underwent partial colectomy defined by the CPT codes displayed here. And then we included both elective and non-elective surgery. Our primary outcome measures were 30-day mortality, 30-day morbidity, and hospital length of stay. So a total of 15,316 patients were included in this study. About 70% of these patients were female with a mean age of 72. About 60% underwent elective surgery, and about half of all cases were done laparoscopically. Due to the inherent differences in clinical management, patients were separated into two groups, either elective or non-elective surgery. And then to account for baseline differences and to overcome some selection bias, we used coarse and exact matching to match patients based on preoperative characteristics within each group, which I'll explain further. And then outcomes were compared between laparoscopic and open approaches. So of the 15,000 total patients, 9,284 underwent elective surgery, which is the aggregate cohort of elective surgery, and about 70% of these cases were done laparoscopically. When we compared the laparoscopic and open groups by preoperative characteristics and risk factors in this aggregate cohort, there were significant baseline differences. And this is where the matching process is helpful to control for these potentially confounding variables. By finding one-to-one matches or pairs of patients with the same preoperative risk factors, we can reduce bias or confounding with these traits. So for the elective group, we matched 3,348 patients one-to-one based on preoperative factors. And then when we compared these preoperative factors again in this matched group between lap and open, there were no longer any significant differences, meaning that our matching process was successful, and that allows for subsequent analyses to be performed that control for these risk factors, and those analyses would be analogous to performing a multivariate analysis. So when we looked at the non-elective surgery group, there were 6,032 patients who underwent non-elective surgery for acute diverticulitis, over 80% of which were done open. And again, there were significant baseline differences in the preoperative factors in this aggregate cohort. So we performed the matching process again for non-elective patients. And we found 1,000 patients that we could match one-to-one based on preoperative risk factors. And again, we checked our matching process to make sure it was successful and there were no longer any significant differences. So these are the outcomes of the aggregate cohort of elective surgery patients, meaning before matching, and this is analogous to a bivariate analysis. So laparoscopy was associated with superior 30-day outcomes, including morbidity and mortality, surgical site infections, postoperative sepsis, reoperation, length of stay, and readmission. After matching and controlling for confounding factors, 30-day morbidity remained significantly lower among patients who had elective laparoscopic surgery. In addition, rates of surgical site infections and postoperative sepsis were lower in the laparoscopic group, length of stay was shorter, and readmission rates were lower. And then when we looked at the non-elective surgery patients, so urgent or emergent surgeries, this is the aggregate cohort. So we found, again, that morbidity and mortality were lower for patients who underwent laparoscopic surgery. We found that surgical site infections, postoperative sepsis rates were lower. In addition, length of stay was shorter. And again, after matching to control for preoperative characteristics, morbidity was significantly lower in the laparoscopic group of patients who underwent urgent or emergent surgery for acute diverticulitis. Rates of surgical site infection and postoperative septic shock were lower, and length of stay was shorter. So this study was inherently limited by the use of a large retrospective database. In addition, these findings are likely not generalizable. The 88% of our study population was of white race, which is not representative of the national patient population. Given the limitations of this database, we couldn't account for procedures that started lap and converted to open. And finally, functional status was not considered in this study, while it remains an important consideration for the elderly population, as age alone is not always representative of overall health. Nevertheless, we can conclude that laparoscopic surgery for acute diverticulitis in the elderly white patient population is not only safe, but it's associated with lower 30-day morbidity, fewer surgical site infections, and shorter length of stay in both the elective and non-elective settings. And therefore, laparoscopy should be the preferred approach whenever possible. Future studies should consider the role of functional status in this elderly population beyond just looking at age, and examine long-term outcomes. And finally, future work should focus on the population of elderly racial minority patients and the benefits of laparoscopy in a more representative group. Thank you.